us for our webinar, which is Demystifying Weight Loss Surgery. We're really lucky to have Dr. El-Juzzi with us here tonight to present about this topic. So I'm going to go ahead and turn it over to him.
Thank you very much. Well, first of all, I would like to thank everyone for joining, ladies and gentlemen. I am very happy to be your, let's say, your host. And full disclosure, I very much enjoy giving those kind of presentations because I think they add value to people and they help people see through. So, starting off, I'd like to introduce myself. Who am I? In a nutshell, and I just elected to have only 3 lines here. I've been in this field for approximately 10 years now. That tells you that I'm very passionate about this. I'm very eager and interested in learning more about the field of obesity and weight loss surgery in general. I have gone through so many years of training, but I just summarized the whole thing through 3 fellowships. One of them was in advanced abdominal surgery, that's laparoscopic and robotic. I also did a fellowship in bariatric and metabolic surgery. And lastly, I did a master's degree in advanced endoscopy. So all of these kind of helped me manage my day-to-day bariatric practice. I'm also a father of 3 up to the 28th of June when my son was born, this past June, so he's about 2 weeks now. So I've become a father of 4 now. I speak few languages and I love traveling. So enough about me. Let's move on and start talking about, those myths. Because we know that a lot of people like to talk about weight loss surgery without having to filter what's true and what's gossip, what's reality from what people like just, to talk about. Especially when you hear a story somewhere, in wherever it is, and then by the time it gets to you, it has already been amplified and so many tales added to it. Well, a lot of people like to say that you really have to be 100 pounds extra, or maybe hundreds of pounds. You have to be in the range of 400, 500, 600 pounds to qualify or think about weight loss surgery. That is not the reality. 82% of the community we treat, or the people, the individuals who come to us for weight loss surgery, are women. And out of these, 40 to 50 is the age that we see most. We see younger, we see older. That tells you that people are really eager in getting healthier, in getting ahead of themselves. I just give you an example. This is kind of like a brief example, although it's not a real example, but my wife was pregnant, and during her pregnancy, she gained approximately 3 pounds. So my perception on weight gain and weight loss is a little different than her because she's a woman. So I appreciate that 82% of our community, or the people we treat, are women. So she gained 3 pounds despite being pregnant. I lost my mind. I thought my son was going to be born malnourished. In fact, he was born 9 pounds and some. My wife was really happy with 3 pounds because she looked after her diet throughout her pregnancy. The people that we treat, most of them don't have hundreds of pounds extra. In fact, 60 or sometimes less than 60 pounds extra weight is sufficient to qualify for weight loss surgery. We go by an index called body mass index, which is a number that it's a calculation that takes 2 factors in perspective, the weight and the height. And then when we calculate, we come up with a few numbers. And these numbers stratify the severity of the excess weight. It goes from normal weight or normal BMI to being overweight, and then obesity class 1, 2, and 3. That helps us kind of stratify who we treat in and who is a candidate and who's not. And actually, most of the patients we treat, most of them have a BMI of 40, maybe plus. Last but not least, you know, as I know, that TV does not tell us the truth all the time. TV is TV. There are a lot of drama. And it really does not represent what we do on a day-to-day basis. Our process is not tedious. When we take somebody for weight loss surgery, we take him or her from A to B, and our process is pretty streamlined. We like to take somebody through the safest journey possible. Obviously, people are different. If I take somebody who is, let's say, a young person, does not have any medical problems, and maybe just the excess weight that is the issue, then the process should be really streamlined. Now, if the person has significant medical problems like heart issues, lung issues, diabetes, these people may require a visit to a consultant, like a diabetes specialist, like a heart specialist, like a blood specialist, which that possibly could make the process a little bit more lengthier, may take a little longer. And we're also dependent on what the criteria the particular insurances work with, because there are some insurances that require certain number of visits to the dietitian versus others who require a certain number of months on being on diet prior to surgery. So for us, the core thing is pretty streamlined, and then we add function of the requirement by the insurance or by the health of the individual. So something else that that we face a lot, which is bariatric surgery is expensive. We cannot afford it, and insurance doesn't cover. Well, the truth is the majority of the insurance plans do cover for weight loss surgery. Sometimes people don't know about this. They are not aware. They may carry an insurance and they have coverage, but for some reason they did not check, or they did not know how to check. What we do, we offer a free insurance benefit check, which is completely free. We only need some details. My team within the office needs some details of the insurance of the people who are interested in weight loss surgery. Then we check, and then we provide them with the details. Now, bear in mind that there is copay, deductible, all that is basically added to the mix. But overall, most of the insurances do cover for weight loss surgery. I've heard this a lot. Weight loss surgery is unsafe. I've heard somebody had this and that. Somebody went through weight loss surgery and ended up having this, or maybe died, or something else. There was a big study that was done by the American College of Surgeons, and there was a recent study that showed that the mortality, meaning dying directly from weight loss surgery, not dying from something else, not dying from, let's say you have weight loss surgery and then 3, 4, 5 months later you die from something that's not related. From weight loss surgery, it was less than the 0.16% that we see on the screen right now, much less than that. Now, we take the risk of death as being 1 in 600 as a reference point, but in reality and in all honesty, it's much, much smaller than that. Weight loss surgery is very, very safe. Actually, is as safe or even safer than having the gallbladder removed. This is telling you that we have evolved from weight loss surgery that used to be done in the 50s, 60s, 70s. We are in 2021. Pretty advanced technology, and we go by guidelines. The complication rate at our center is less than the benchmark, the nationwide benchmark. In other words, our complication rate is less than what we see on the different papers published from different centers across the country. Weight loss surgery helps people. Weight loss surgery, or bariatric surgery, improves the health of people. There are so many papers, and I don't mean to bore you with numbers, but it really helps people. By losing the weight, you decrease the load on the heart. The heart pumps better. The sugar is better handled. Diabetes improves. Women, especially young women, who have had problems with fertility, they are sterile, they become fertile. I've seen it, I've witnessed it myself. I've had patients that they become pregnant while they were losing weight. I have stories about that, which is awesome. It really helps people from a lot of perspectives. The least you can enjoy is just looking better, looking younger. It's less of you in a way, wearing the clothes you want to, walking without having to have the pain in the knees or the hips, and just enjoying yourself. Being a person who depression goes away and many medical problems either improve or are just vanished. Weight loss surgery changes lives. A lot of people think about surgery as the last thing on the list from A to Z. The last ditch, the last resort. That used to be the truth. I agree with it. Maybe that was before my time. I think I'm lucky. I live at a time where technology is very advanced. I mean, here we go. We're on Zoom right now, and so many of you right now joining me in this awesome meeting. We couldn't have this maybe 5-10 years ago, or this was not the vogue. Now it has become a vogue, and we can reach a much bigger number of people just by being on the internet. Same thing with surgery. In the old time, surgery used to be pretty frightening, and I must say, having those big incisions was not something too attractive to people. But we have evolved. Now we use laparoscopy, we use robotics. The people or the cases that used to last for hours in the operating room, now we do them in incremental times, like we like to say 60 minutes, 90 minutes, maybe 120 minutes. We don't talk about hours, like an hour or 2 hours in the operating room. It's like 60 minutes, 90 minutes, 120 minutes. It's awesome. The gastric bypass, for example, when it used to be done open, used to take hours, and the patient would go straight to the ICU, stay there for about 3 days, maybe 4 days, maybe a little less, and stay in the hospital for a week before being discharged home. I do my robotic gastric bypass, and it takes me less than 90 minutes. My patients stay one night in the hospital, and next day they feel terrific, and they want to go home. And maybe not everybody, but most of they stay in the hospital 2 nights. That's a dramatic change from what used to be decades ago. So, to be back on track, to consider surgery as a last resort because you're afraid of being called failure, that's not true. In fact, as you allow the excess weight to wear out your body, the chances of fixing the damage is much less as you progress with time. In other words, the earlier you seek help, the earlier you get the help, the better is the outcome. In fact, we see it all the time. We see people younger and younger having awesome outcomes. Same thing with a little older people, but truly speaking, we know that there's a difference. The younger you are, the earlier you seek help, the better is the outcome. Obesity is not a matter of willpower. I keep saying it, I always tell my patients, obesity is a complex disease. It's not a matter of, oh, let me try this diet, or let me see this dietitian, or let me look at this program on the net, or let me do this Zumba dance, or this. I mean, all this may work, but there's nothing that's gonna lead to a sustainable and significant weight loss better than surgery. It's been proven through very strong publications. We have people who are extremely happy, and it changes lives, which is awesome. Other people think about weight loss surgery as leading to failure no matter. In other words, they say, you know what, I've done everything possible. I've dieted, I've seen X, Y, and Z, I've seen that physician, I've tried this, I've tried that. And then I landed in the hand of this surgeon, and he did surgery. It was awesome. But guess what? I lost weight. A year out, I lost 160 pounds. And then what? Yeah, I regained everything back, or most of it back. Does that happen all the time? No. Truthfully, no. Do people regain some weight after surgery? Well, yes, because physiologically speaking, we all age. I'm aging. I'm not that guy that used to be in his 20s. If I display my pictures when I was in my 20s, I looked healthier and fitter. Thank God my wife is still with me. But I used to be much healthier, not healthier, much fitter than now. As we age, the metabolic rate slows down. And by doing so, there's a tendency to stack up a little bit of weight. But it's the same thing with somebody who just had weight loss surgery. It is not, there's no exception. But we do accept 10%. We do accept 10% of weight regain, which is, somebody who, for example, lost 100 pounds and then regains 10 pounds. You still have 90 pounds off, which is awesome. It's not like regaining the whole thing. Now, here's the thing. There are people who do regain most of the weight back. And you really have to keep in mind that weight loss surgery is 2 stages, not just one. I'll repeat this because this is really key and it's very, very important. Weight loss surgery is 2 stages. There is the easy part, which is losing the weight. We do surgery, you have the follow-up, you have people around you, the surgeon is calling, come in and have your follow-up, the dietitian is here to help. And then you're excited, you're losing weight, you're shedding it off, you look awesome, you keep losing, then you reach your goal, you're very happy. But then the second phase starts, which is the long-term follow-up. You need to be devoted, you need to be committed to your health as being part of that team. Disconnecting from the team that cared for you for, let's say, a year or year and a half, it's not a wise decision. Because without being accountable to your health, without being in that environment where you can seek help anytime, we can knock at the door and say, hey, for some reason I just regained some weight and I don't know what's going on. Can somebody help me? Of course, we can reconnect you with a dietitian. We can refer you to our medical weight loss. They can help you with this and that. We will refer you to the fitness specialist. They're gonna help you refine your exercises and then basically boost up your health. So that follow-up or the second phase is golden. It's very, very important. And actually, if you read the last sentence here, long-term results take effort and intentionality. So you really have to be intentional about what you do. You have to be committed and you have to be committed to the team. There are so many procedures that we offer. And to be honest with you, I love this talk. I love talking about surgeries. And I love talking about what we do and how we can help people. So there's so many procedures that we offer. We offer the endoscopic part or the endoscopic procedures, which are not really displayed on this slide. But I personally do a lot of endoscopies and we can help people through endoscopy. But our to-go procedures, or let's call them the procedures that have established presence, have shown efficiency, are the procedures that you see displayed. So the sleeve and the bypass are my favorite procedures. The lap band is another procedure that's been around, and it's been around for a long time, and it has its own indications. It's maybe not for everyone. Currently, we see more people leaning toward the sleeve or the bypass, and then there are revisional surgeries. What does that mean? Revisional surgery. Well, revisional surgery is when somebody had some sort of weight loss surgery in the past, whether it's a sleeve or the bypass or a band, or some other procedures that used to be done in the past, like a VBG, ilio bypass, and other dinosaurs, let's call them that way. Other procedures that used to exist in the 70s, the 80s, and the people right now having problems. Well, we take case by case and would love to consult with people and help them. And maybe they're a candidate for revisional surgery. We can take them from that procedure that may have worked for a while, but then has become inefficient. And it was a procedure that faded away. And now maybe it's time to revise that procedure in something that that probably will work, very likely will work much more efficiently than the original surgery. I really love this slide, and this is not by me. I give credit to Tina. Tina is my program coordinator, and we were talking about this, and I love this. And actually, there's a saying that if you have tried the same thing over and over and over, and has led to the same results over and over and over, what would you carry? What would you carry on doing the same thing? Why wouldn't you consider something more radical? Something that's going to take you to the next level in your life. There's a famous saying, change your standard, change your quality of life. I'm a big advocate for that statement. So what's your next step? It's very basic. We offer consultations, either via the Zoom, like right now, or in person. We like to consult with people. We like to go over the medical history, check the benefit, and then basically give our recommendations and our education to people who are interested in weight loss surgery, or people at least, even if the people are on the fence, people who are still not convinced 100%, they may want to hear it from me personally on a one-to-one basis, and then they may want to just ask their specific questions. And I'm more than happy to draw sketches, which I love doing, and basically make the process sound, very smooth and flawless, and hopefully no hassle and straightforward. I thank you for your time. I hope this has added some value and has cleared that little maybe foggy, perception on weight loss surgery. We just open the floor to questions. Alexis, it's yours.
Thank you, Dr. Aljouzi. So just to remind everybody, the chat button is in the bottom of your screen. And if you have any questions, you can click my name and send them over to me. For now, I do have a couple of general questions to start. So are there any side effects to weight loss surgery?
Side effect means complications. Okay, so the complication rate from weight loss surgery is very, very dismal. In other words, the true complications, which are bleeding or a leak. A leak means whenever we do surgery, especially if it's a stapled procedure, whether it's a sleeve or bypass, we like to use special instruments. So we cut the tissues, and that special instruments also seals the tissues. The leak means the content of the GI tract, the gastrointestinal tract, could be seeping outside into the abdominal cavity and creating problems. So these are really the two main complications that we always like to talk about, yet they're extremely infrequent nowadays. Why? Because we have very advanced technology. And we see either the bleeding or the leak, probably it's in the range of 0.2%, extremely rare. And the bleeding most of the time stops because it's not significant. And leak, we do understand it better. We manage it better. We have the tools. We know how to take care of it, not like what used to be in the past. So they're not dilemmas. They are things that we're not afraid anymore. And thank God they are extremely rare, as I said, because our techniques and technologies have evolved. Now, other complications like nausea, pretty common, but it's very mild, very controllable. Dehydration after surgery, especially when somebody is not drinking. That's the reason we like the education. We like to educate people on how they should drink and when they should drink and how much they should drink. And then infections of the wounds, which in all honesty, I have not seen any, at least for the past 5 years. So it's something that's unheard of. Last but not least, blood clots like DVT in the legs or blood clots going to the lungs. We give every patient blood thinners before surgery. And then we give blood thinners at the time of the hospital stay, and the patients are up on their feet right after surgery. That's the beauty of minimally invasive surgery. So they are tiny, tiny, tiny incisions. There are 4 incisions. And our patients are up on their feet right after surgery when they're fully awake, and they start walking, drinking, and breathing. So we see the complication, as I mentioned earlier, our complication rate is extremely, extremely low.
Great, thank you. And one more question related to this.
Yes.
Do you think that there would be any potential complications due to COVID?
You mean if somebody had COVID before and now is willing to have weight loss surgery?
Yes.
So we all know that this COVID thing is pretty new to us. I mean, COVID or the coronavirus is a virus that has existed since humanity has existed. But this COVID-19 pandemic is something pretty new. I haven't heard, talking to colleagues of mine, I haven't heard any problems with people having had COVID before and they recovered and now they undergo weight loss surgery, having any issues down the line. Now, if somebody is having COVID right now, obviously we cannot do surgery. That's the reason we pre-screen our patients. But it's not a contraindication. And I don't think it really deserves any, any deep thinking. And actually, people who have had COVID and recover, they have antibodies. So that means they in a way, they are vaccinated, which is a very good thing for them.
Great. The next question I have for you is, what is the expected recovery time after some of these procedures?
Awesome question, and I love this question. And I'll be very truthful to you. So this is how it works. The person, I'll take this journey in like a couple of minutes. So let's say everything has been done. Everything has been, the insurance pre-authorized for the surgery. The patient goes through everything, and then today is the day of surgery. The patient comes in a couple hours prior to surgery. All the work is done. The patient is prepared. We move on to the operating room. The surgery, as I mentioned earlier, takes anywhere between 60 minutes, 90 minutes at most. If it's a revisional surgery, it may take a little longer, maybe 120 minutes. Well, but we're not talking about hours anymore. We're talking about, as I said, 60, 90, 120 minutes. So the patient recovers from surgery. There are no drains. There are not tubes sticking out from the mouth, from the nose, bladder, catheter, any kind of drains. None of that. The only thing the patient has is an IV line in one of the veins just to give the patient some fluids and medication as needed. The patient goes straight to what we call PACU, that's post-anesthesia care unit, and the patient will stay there for a couple hours. That could be 2, maybe 2.5 hours, depending on how the recovery is. And most patients have, I say 99.9% of the patients have a straight, smooth recovery. And then the patient will be going to the floor. There's no ICU, so we don't do ICU. ICU used to be in the past, like a remote past, but now, because our patients are through tiny incisions, as I mentioned, like 4 tiny incisions, they recuperate really well. Then on the floor, a couple hours later, when the patient is fully awake, so the anesthetic drugs have gone away, then it's time to start action. The action is drinking, walking, and breathing, deep breathing. I always tell my patients, don't think, just do those 3 things. Breathe, walk, and drink, that's it. And that day is a kind of a challenge for the body. Most patients feel a little anxious, a little bit pain, not excruciating pain, that's normal. But after walking a little bit and drinking and breathing, they feel better. The next day, most patients are ready to go home. Now, some may not be that ready, and they may stay another night. But at most, what we see, it's 2 nights of hospital stay. The patient goes home, and they are basically freed from everything. So all the incisions are healing. They have either glue or little tapes which are waterproof, so the patient can shower right after surgery. They cannot swim or use jacuzzi or the bathtub for about 2 weeks. They cannot exercise for about 6 weeks. They cannot lift anything beyond 10 pounds for 2 weeks. But they can do everything else. They can walk. They can drive their cars if they are off pain medication. And truthfully, the pain medication is only used for about 3, maybe up to 5 days. The first week, at the end of the first week, the patient will feel like 80%. By the second week, they are approximately 100%. Long story short, I just told you about all this. It will take approximately 2 weeks to feel really good, to feel like I can go back to anything I would like to. I'll give you an example. I had a patient of mine that I did a gastric bypass and he was discharged the next day. I had a follow-up with him, I think it was yesterday. And he works in construction, and he wants to go back. He wants to go back as soon as possible because he feels terrific. And I told him, no, you get to wait for 2 weeks at least. It just feels awesome. Yes, 2 weeks is what we see. And then after that, surgery is history.
Great. The next question is, how drastic will someone's diet change after this surgery?
So this is an awesome question too. That is the reason we have, that preparation before we engage the surgery. We never take somebody from the current state and then we go through surgery and we ask, the person to change drastically, the diet. And I don't like that drastic thing because it's not that drastic. In reality, we educate people to change the mindset, to start thinking differently about diet, about food, and the quantity and how much they need to eat, the composition, everything else. So rather than having the big plate, that could be really condensed, and you can have very nutritious meals, and they can be much smaller. But what happens after surgery, whether it's a sleeve, a bypass, or any other procedure, people will eat less. I'll give you an example, the sleeve, to make it simple. The sleeve, when we take the stomach, when we take most of the stomach out, so the stomach used to be 1 liter, now it's about 4 to 5 ounces. So people can tolerate about 4 or 5, maybe stretch it to 6 ounces before they feel full. So a meal will be about 6 ounces. But here's the thing, 6 ounces, if the meals are really nutritious, that's sufficient to maintain and lose weight at the same time. Because if you're taking proteins and you're taking the right things, you will definitely lose the fat versus doing it the other way around. So it's not that drastic, but there is a change, and we help people understand the transition. And the transition most of the time is very smooth because we take time prior to surgery through our dietitians to educate people what to do, how to do it, and we haven't seen problems. Obviously, it's a change, but it's not something that people don't get, what's the word, get used to it. It's something that becomes natural with time, and that's the life. And actually they enjoy it. After a while they say, oh, why didn't I think about doing it this way? Well, they didn't have the tool. They didn't have the bypass or the sleeve. Otherwise they would have done it.
The next question is, what is the difference between the sleeve and gastric bypass?
So in a nutshell, so the sleeve, well, let's go back we start with the gastric bypass. I think it's better. And I think I can go back one slide to show it better. So the gastric bypass, well, is a surgery that has been around for a long, long time. And in fact, the gastric bypass is started in late 50s and has matured since. And now we've seen a version that really works. It did work before, but now the surgery itself, it's so, what's the word? It's so well stratified, all the steps, we know how to do it, we know how to do it really well, that we can project the results, okay? The sleeve gastrectomy is an awesome procedure too. It's just younger. It's been around for about 20 years. It was never meant to be a standalone weight loss surgery. It was a first step before another much more complex surgery called duodenal switch, which is only done in 1%. It's like represent 1% of all the cases done, actually, not just in the US, maybe in the world. It's pretty aggressive surgery that I personally don't do. So if you have the chance to look at your screen, this is the sleeve. So the sleeve, basically, we divide the stomach into two portions. One is about 85%, which will be gone. And the remaining of the stomach has almost like a tube shaped or a banana shaped. It's about 4 to 5 ounces, as I said earlier. And for tall people, it may be more than that, maybe 6 ounces or so. So the sleeve gastrectomy is a surgery that focuses on the stomach. There is no rerouting of the bowel. We don't touch the bowel. We don't do anything with the bowel. It's all about the stomach, okay? With the gastric bypass, it's a little different. With the gastric bypass, we create a little pouch, which is only 1 ounce, and there's a rerouting of the bowel. In a way, we create this kind of architecture, where when food comes down here, it sits in the pouch, which is 1 ounce. That's a mouthful of anything we eat, and then it starts traveling down through the bowel. And the beauty of this procedure is the food that travels through this part of the bowel does not get digested. That's the reason this is very powerful and really helps people lose tons of weight. The chances of regaining, as I explained earlier, is significantly decreased. And then we see a lot of good benefit from this procedure with diabetes, heartburn, and many other problems like the heart and what have you, similarly to the sleeve gastrectomy. Both procedures are, the best way I look at it is case by case. I really like when I sit down with my patient to see what they like, what they've heard, if they had people who had some good experience with this procedure or the other. Because most patients, when they come to my office, they particularly ask about one specific, but they're open-minded. They say, I have a family member who had a sleeve. I really want to mimic that. I really want to replicate, the results they've had, but I keep being open-minded. If you think the gastric bypass is better, I'll go with it. If you think something else is better, I'll go with it. And vice versa. I see people come in with a gastric bypass, open-minded, and I see other people who just come in and they undecided. And they're open-minded. They say, you're the doctor, tell us what you think. Then what I do, I go through the clinical history and I really see which procedure fits the individual the best.
The next question is, how often is additional surgery needed after the weight loss surgery?
So I have a mantra I like to share with my patient. I tell them, when I do surgery, I want to do it once. So that's my mantra. I never shoot for the second operation. I never plan for it. And I'm going to share this with you. I like Arnold Schwarzenegger. He has some pretty powerful speeches. One of them is, he keeps saying he doesn't have plan B. So I tell my patients, don't have a plan B, have a plan A. The plan A is one surgery that's going to lead you to your goal. And as I explained earlier, you lose the weight, that's phase 1, stay with us. We are here to help you maintain that weight. So if you do this, you should never require a second operation. Now, revisional surgery do happen though, and it does happen for various reasons. Sometimes people do regain weight because they're out of the loop, out of the follow-up, and they regain weight, they regain excessive weight, and then we have to intervene. And I do that in my practice. And actually, luckily, all the revisional surgeries are not my patients. Patients that come to me, being referred to me from elsewhere, where I have to basically take them from where they are right now to a different procedure. But in reality, and I keep saying it, if there is a full commitment and the individual really commits to the process, the chances of requiring revisional surgery is very dismal, very, very dismal.
Thank you. The next question is, which option is the least invasive?
All of them. All of them are least invasive. I know there's this apprehension about, for example, people like the idea, if the sleeve is a simpler operation. Yeah, it is simpler. But the gastric bypass is not a complex procedure, or it's not as complex as people think. Because right now we're talking about these operations, the operations we see right now on the screen, because these are kind of the most we do. And actually the sleeve and the bypass is the most we do. And I look at the bypass and I look at the sleeve as equal. And actually I share with my patient, I tell them, the nurses on the floor don't make any difference whether you had a bypass or sleeve. Why? Simply because the number of incisions are the same. The recovery is the same. The diet is the same. The follow-up is the same. The vitamin supplements is the same. The only difference is the anatomy. And for somebody who's not an average person. And excuse me if I use this, but an average person means somebody who's go by the book, follows all the instructions, but not a champion. A champion is somebody, when I tell him jump, would say how high. So if I say do it twice, he will do it 4 times. So if you're a champion, whether it's a sleeve or the bypass, you will achieve terrific goals. You will lose tons of weight. And I have examples. I have tons of examples. Now, if you're average, an average person means you really kind of like to do it by the book, but not go beyond that. You will still lose tons of weight, and there's really no difference. And the recovery, actually, as I shared with you, the gastric bypass would go, would spend 1 night in the hospital and go home next day. And like my patient is willing to go back to construction, and he's only 1 week out. We see the same thing with the sleeve. Now, if I touch a little bit on the band, I personally, I don't favor the band. That's me, because I've seen better results with the bypass and the sleeve. It does not mean the band is not indicated, but it's really, what's the word? It's really indicated to a very, very narrow subset of people. Very, very specific indications for when we do the band versus being more liberal about the sleeve and the bypass.
The next question I have is, what type of anesthesia is used to put patients under during these procedures?
So anesthesia is general anesthesia. We don't like patients to be awake because that doesn't make any sense. So general anesthesia, so we assess patients before going through general anesthesia. Obviously, we need to check all the boxes, cross the T's, dot the I's. But it's general anesthesia. So patient will not remember anything, will not feel anything, will not remember anything. I personally had 2 surgeries in my life. General anesthesia, both of them. I lost my appendix. I don't remember any details. I woke up and my appendix was gone. I had a little bit of pain, recovered, awesome, happy. I had the second operation, same thing. So general anesthesia is a must. And the only time we possibly do some conscious sedation, which means it's not really general anesthesia, it's less, is when we do endoscopy. But that's very limited indications. But as a rule of thumb, general anesthesia is the way to go for every single bariatric procedure we do.
Are there any age restrictions to these procedures?
It's an awesome question. Because technology keep advancing, so we stretch that. We keep stretching it. So as a rule of thumb, we take people from 18 to 65. But then we take also people beyond 65. It's a case by case. Because we like to look at all aspects of their medical history, what kind of medical problems they have. We need to make sure that they can go through surgery very safely. But as a rule, 18 to 65. Now, why don't we take people who are younger than 18? We don't do it at our institution. I'm hoping that we will open up and do it more in the future. But bariatric surgery is also indicated for adolescents in this era. And actually, there are centers across the nation that they do surgery on people who are 15, and now it's going down to 12. And abroad, let's say in countries where obesity is more than 40% of the population, like for example in the Middle East and other countries, they do bariatric surgery on children, and it helps, because otherwise, if they don't do that, those children would die from heart attacks at the age of 18. So they have to intervene at a very younger age. And that's really very, very advanced kind of bariatric surgery, because it's very, younger population, small population. So 18 to 65, but we take people beyond 65 on a case by case.
Thank you, everybody, for joining us tonight.
Thank you.